Hello, dear attendees of the ASCO Congress. Bonjour à toutes et à tous. I am Léonore Fatz. I'm a clinical psychologist at Gustave Roussy Cancer Care Center, and I'm also a professor at Paris Cité University in France. So I'm very pleased to present you today some of our research concerning the psychological adjustment and perception of patients, relatives, and healthcare providers regarding continuous deep sedation until death. This is a mixed method study. First of all, I have no conflict of interest, and this research is funded by the French National Cancer Institute, INCA in French. Here you have all our partners. Okay, to introduce this presentation, maybe I have to precise some information. So continuous deep sedation until death, which I will mention as specific sedation for the rest of this presentation, is procedure covered by the French law of February 2016, the La Loi Claes-Leonetti, creating new rights for patients with terminal illness. Among several palliative sedation, this specific sedation is a response to refractory physical or psychological or existential suffering of the patient, which should be informed of this therapeutic option. This practice is strictly reserved for patients whose impending death are expected within a few hours to a few days. And the vast majority of patients who receive this specific sedation are patients with cancer. So the French National Center for Palliative Care and End of Life reported in 2018 that despite the adoption of this law 8 years ago now, polemics are still running regarding this sedation. And the report also mentioned that this procedure is not really integrated in the dedicated care structures yet, which of course testifies of the non-routine nature of this specific sedation, but also perhaps to the fact that the procedure is not clear to all, including patients, their relatives, and the healthcare providers. The rare studies concerning the continuous deep sedation until death mention a critical lack of knowledge regarding the psychological experience of patients, their family, and the healthcare providers. The majority of the articles dedicated to these topics are ethical studies, which is of course very interesting, but these articles, these studies do not document the psychological adjustment of these individuals. And of course, as you might know, bereaved individuals in the cancer context constitute a vulnerable population. They are at risk for developing a critical amount of physical, psychological, detrimental outcomes. Trevino in 2000 18 reported that 44% of bereaved individuals in the cancer context develop depressive symptoms, anxiety, and 10 to 15% of bereaved individuals, whatever the context, are vulnerable to prolonged grief disorder. So the lack of knowledge regarding the psychological adjustment of relatives and healthcare providers that I mentioned earlier prevents us from offering relevant support programs for bereaved individuals and professionals. So the main objective of the Apsy Sed study is to describe this psychological adjustment and the perception of relatives and HCPs of patients with cancer from whom this specific sedation is discussed. There are other secondary objectives, but today I will focus on the primary one. So Apsy Sed is a longitudinal, multicentric, and mixed method study. If you want more details regarding the protocol, you can find them in this publication in BMC Palliative Care 2022. This is a paper. And as I mentioned, and as you can see, this is a multicentric study. So we recruit all over France now. And this is a longitudinal research with 3 assessment time. The first one, T1, assessed various variables around the time of the specific sedation, just before the death of the patient. So we collected demographic and clinical data for the patients. We assessed the intensity of the depressive symptom, of the anxiety symptoms in the relatives of the patients with cancer. We also assess the attachment style, the satisfaction with end-of-life care. This is for the relatives. And among healthcare providers, we assessed their job satisfaction and their professional experience with the Karasek questionnaire or job questionnaire. And we also conducted interviews for relatives and healthcare professionals that wanted some interview. So we have a second assessment time, 3 months post-death for HCPs and 6 months for death for relatives. And the third assessment time is just for relatives, 13 months after the death of the patient. But today I will focus on T1. So these are the results. The current results for T1. I'm not sure you can see the demographics here, but we recruited 44 relatives. The 61% of them were children of the patients with cancer. In average, I think they were 50 years old. 52% of them were men, and 52% of them were graduated. We also recruited 34 healthcare professionals. They were 36 years old, 50% men, 50% women, and 44% of them were nurses, and 29% of them were physicians, but we also have auxiliary nurses, And on average, they work with patients with cancer for a little more than 7 years. So the main results for T1 are that in relatives, we can observe high anxiety scores with STAI inventory. They reported high satisfaction with end-of-life care. We can see that women reported higher depressive symptoms than men. And BDI score, which means depressive symptoms, were negatively correlated with one subscale of the satisfaction with end-of-life care, more precisely the needs of the relatives. And the STAI scores are negatively correlated with another subscale of the satisfaction with end-of-life score, more precisely with the implication of the caregiver. So in healthcare providers, 26% of them reported job strain, and there is a negative correlation between perception of job support and age. I will now present you the qualitative results analyzed with the Iramitech software, which is a lexicometric software. In the left of the screen, you have a similarity tree for relatives, and on the right side of the screen, you have the same tree for healthcare providers. This similarity tree show you the most frequently cited words in both population. So as you can see, relatives talk about the suffering of the patient with cancer and the importance of communication with healthcare provider. And they talk about the temporality of the sedation. For healthcare providers, they talked a lot about the technical nature and the technical difficulties associated with the sedation, and they focus on the importance of the family and the time that they have to dedicate to the patient's family. So here you have a little table. As I mentioned earlier, the relatives focused on the nature of the temporality associated with this specific sedation, and they describe this moment of goodbye to be tamed with a ritual. And they also underline the unbearable nature of the pain of the patient of their loved one, and they stress the need for communication with HCPs. The HCPs underlined the importance of the patient's will and of the law, and they focus, as I told you, on the technical challenges related to the implementation of the specific sedation, and they stress the importance of taking time with the family. We can also mention similarities between relatives and HCPs. Their common goals are related to the absence of pain, of distress in the patient, and we can notice an important confusion between continuous deep sedation until death and euthanasia, or more broadly with active assistance in dying, I'm sorry. So, in order to conclude, we can state that despite high satisfaction with end-of-life care, the majority of relatives reported intense anxiety symptoms, which are related to the abrupt temporality associated with this specific sedation, despite all the explanation offered by the HCPs. This temporality remains abrupt. For instance, Gina, who was a daughter of a patient with cancer, told us what's so stressful is that it can last from a few hours to a few days, and it was very confusing. This distress was in line with previous studies, but our study brings more specificity regarding the very nature of this distress. This distress is not depression or guilt. It is anxiety regarding the temporality. This specific sedation seems to give rise to the establishment of a ritual which would allow one to control the moment of the operation, which rings a bell with Van Gennep's work regarding rituel de passage, transition rituals at the moment of the death. Second, the majority of HCPs reported feeling comfortable about the specific sedation, which contrasts with previous study. Of course, some HCPs of our study mention emotional burden, but in the specific context of treatment limitation. One hypothesis which can help us to explain this emotional burden is that these distressed HCPs mention feeling more active in this procedure, and these HCPs are the one that reported a confusion between sedation and euthanasia. And the work of Raus and Ries regarding perceived causal closeness, which is associated with psychological distress, can help us to explain this emotional burden, because these HCPs might perceive their causal role in the death of the patient. So the main limitation of our study is, of course, the small size of our sample, which hinders the statistical strength of the analysis, but the study is still going on and we are still recruiting. So I really hope that we will have 100 of relatives and 100 of HCPs for our next analysis. And the longitudinal design of Apsy Sed study will allow us to refine our first results. So the take-home message of this presentation are first, overall relatives and HCPs appear adapting well to this specific sedation and appear being rather comfortable in this context. Relatives insisted on the importance of quality communication with professionals, and the latter also placed the family at the heart of their concern. It is thus crucial to continue training in communication skills in HCPs. And finally, confusion between sedation and active assistance in dying persists. And as you might know, there is a law in draft concerning active assistance in dying. So it is critical to clarify the various procedure in HCPs, in patients, in relative. That is why early, anticipated, palliative acculturation is absolutely needed, and improved knowledge on the part of HCPs will lead to improved perception on the part of relative. So, thank you so much for your attention. If you want to contact me, please do it at Leonor, Leonor dot Fasse, Fasse, at gustavrossi.com, and I will very happy to answer to your question. Bye bye.